neurology, ophthalmology, refractive errors, lens disorders, and glaucoma. All right, so for this next chapter, we're going to be talking about the eye, but the eye has a lot more to it than the ear does, so we're going to be breaking it up a little bit. The anatomy of the eye, in my opinion, isn't too important. Take a look at the diagram to understand what the overall structures are, but majority of the time, it really doesn't matter too much. So I'm just going to dive right into the refractive errors. So the refractive errors, you've probably heard of them multiple times. It's nearsightedness or farsightedness. So it's hyperopia and myopia, all right? Myopia is nearsightedness. Hyperopia is farsightedness. Now, once again, my rule of thumb is to just memorize one thing if the other thing is just the opposite of it. So just memorize hyperopia and you'll be good, okay? Because the myopia will be completely opposite. So hyperopia is farsightedness, and that means that the eye is too short, okay? And since the eye is too short, that means the light is focused behind the retina, all right? And what you need to do to correct it is to have a convex converging lens so that all the focal points, or the focal point and all the light rays can reach one focal point directly on the retina, right? In hyperopia, that focal point is usually behind the retina, okay? And same thing goes for myopia, but the opposite. Myopia is nearsightedness, okay? And it means that the eye is too long. So all of those light beams are going to be focused into one focal point in front of the retina, all right? So what we need to give them is a concave diverging lens in order to make that focal point closer to the retina. Now, if they can say, they'll say myopia is due to an increase in anterior posterior diameter of the eye, okay? That's just another way of them saying that the eye is too long. Increased in anterior posterior diameter. And that could be a potential question. So remember, don't get bogged down too much about like certain wording of questions. Take your time, read it, and be like, okay, what are they trying to tell me here? When they say increase in anterior posterior diameter, what are they trying to let me know? What are they trying to hint at? And they're just saying that the eye is too long. And then talking specifically about myopia. All right. And that goes for pretty much majority of step one. They will give you so many answers that doesn't sound like what you're truthfully looking for, right? Because if you were looking for myopia, you'd probably be looking for like the eye is too long, right? But they won't say that. They want to hide it a little bit better, okay? So they'll give you it in a different manner. And that's how it is for majority of questions. So my recommendation to get around that is to just read the words that they're trying to explain to you, and then put in synonyms that you know for the words that they have provided, all right? And that way, maybe you're like, oh, this is what they're trying to tell me. All right. Next is going to be presbyopia. We already discussed presbyopia a little bit, but all presbyopia is that it's age-related impaired accommodation. So you don't have the ability for the lens to accommodate to close objects or like near objects when you get older. All right. So accommodation, I think I should probably explain accommodation. Accommodation is essentially when something gets close to your face, all right, when an object nears you, your lens constricts. The muscles for your lens start to constrict, okay? And they point the lens rather than have a flattened lens. And when you point the lens, that helps you see near objects. Now, over time, that elasticity of those muscles that constrict the lens, they can get slack, and that can lead to presbyopia, which is just age-related impaired accommodation. So age-related impaired ability to constrict that lens. All right, very important. But presbyopia does not mean that you have loss of visual acuity. So think about your parents, for example. They need reading glasses, but they don't need glasses every single day, right? Majority of adults don't need glasses every single day. They just need reading glasses because when they're reading, it's close to their face and they have a harder time accommodating because of presbyopia. But it doesn't affect their overall visual acuity. They're still able to drive without glasses and do normal everyday things without glasses, okay? So it does not affect the visual acuity, all right? It just decreases lens elasticity, which is accommodation, and so that's why they need like reading glasses for up close things. Now, something that they like to ask about is that myopia superseded on presbyopia, so myopia and presbyopia occurring at the same time, can compensate for one another and give a patient normal vision. So they could say, oh, well, a patient has had myopia his whole life, all right? And remember, what is myopia again? Myopia is nearsightedness, right? So that means that the eye is too long. So they said, oh, they have myopia, they have nearsightedness for their whole entire life. They've needed glasses their whole entire life. But now as they've aged, they're in their 60s, and all of a sudden, they don't need their glasses anymore. It's because presbyopia on top of myopia actually normalizes a patient's vision, okay? They just essentially cancel each other out. So that's something that they like to talk about. Next is cataracts. All right, so what is cataracts? Cataracts is essentially just like the blurring of someone's lens. All right, so imagine you're taking a photo of your camera and you pull up the camera on your phone and it's like all greasy and like foggy because you have like your fingerprints on it. It's the same thing occurring on the lens of our eyes. We have just greasy, essentially cloudy lenses, okay? And they say it's an opacification of lenses. That's our $1 million word. The $5 word is like a greasy, cloudy lens, right? So what happens is that the patient's going to present to you and they're going to say, wow, I have so much glare when I'm driving. I have decrease in vision at nighttime, okay? And they also have the loss of the red reflex. Okay, those are 3 things that they really like you to know. Now, another thing is risk factors. Increased age, obviously, is going to be the number 1 risk factor. As you age, you have increased risk of cataracts. One of the doctors I worked with, he told me, the best thing to go into is ophthalmology because as long as people live for a while, they will have cataracts, okay? It's just a matter of if they live for a long time. And if they live for a long time or a long enough time, they'll get cataracts. So he's essentially saying 100% of people get cataracts. I mean, I don't know if that's the truth. It probably isn't. But it just goes to show increased age is associated with cataracts, along with tobacco smoking and other risk factors. But what I will say, one that they like to test on is glucocorticoid usage. Prolonged glucocorticoid usage, as well as diabetes, uncontrolled diabetes, can be associated with cataracts. And we discussed why diabetes was in the endocrine chapter, but prolonged glucocorticoid usage is also associated with the cataracts, okay? So keep that in the back of your mind. You also have torch infections associated, like rubella, that they like to talk about as well. Now, once again, cataracts is just the opacification of the lens, that's our $1 million word, with loss of vision due to oxidative injury. So it could be due to any type of oxidative injury, and increased age, tobacco usage, glucocorticoid usage, diabetes. It could be due to torch infections like rubella, and so on and so forth. But just keep that in the back of your mind. Next is lens dislocation. So the reason I'm bringing this up is because there's 2 main pathologies that you need to know that has lens dislocations. And the way in which the lens is displaced tells you specifically what pathology it is. So if you see a patient that has lenses that are displaced up and outward, that is Marfan's, okay? And the way that I remember that is that Marfan's people are very tall. They grow up and out, okay? So Marfan's people are very tall. They grow up and out. So their lenses are going to be up and outward. Homocystinuria is another pathology associated with lens displacement, but they have down and in displacement of the lens. So those are 2 different pathologies that they want you to know, okay? And they can present somewhat similarly, but keep those 2 differences in mind because that helps you in identifying what pathology they're talking about, all right? Now, next, we're going to be discussing glaucoma, okay? So kind of before we go into depth into glaucoma, I need to tell you about how, I think this is where anatomy is going to be a little bit helpful. What happens to our aqueous humor? Okay, so aqueous humor is what is essentially in our eyes, okay? Aqueous humor is present in our eyes, okay, in the anterior portion of our eyes, all right? The posterior portion is vitreous humor, and that's in the vitreous chamber, and that's everything posterior to the lens. But everything anterior to the lens is the anterior segment, and that has our aqueous humor, all right? So let's take a step back. I kind of want to explain just the anatomy one more time. So looking at the eye from anterior to posterior, I'm going to move from anterior to posterior. I'm going to start with the outermost layer. The outermost layer is the cornea, okay? And as you keep on going in, you pass the cornea, you're going to reach the first area. It's just like this area of space or air that's filled with aqueous humor. That's the anterior chamber, okay? And then you're going to go into the pupil, which is surrounded by the iris, right? And that's going to enter you into the posterior chamber. So the posterior chamber and the anterior chamber are separated by the pupil, which is just a hole, all right? And then while in the posterior chamber, you're going to continue to move backwards and you're going to reach the lens, okay? And so at the lens, there's going to be a separation. So the anterior chamber and the posterior chamber make up the anterior segment of the eye. And that stops at the lens. Everything posterior to the lens is known as the posterior segment of the eye. I know it's very confusing, but the anterior chamber and posterior chamber are in the anterior segment. And then everything else is in the posterior segment, okay? So once again, none of this really matters too much, but I just want you to have an idea of what the anatomy kind of looks like when we're discussing the aqueous humor flow. We're not going to be in the posterior chamber or segment at all. We're going to be in the anterior chamber and the posterior chamber, which is the anterior segment, okay? So now that we're talking about that, we can kind of discuss the aqueous humor pathway. So there's 3 things you need to know about the aqueous humor pathway. First off, aqueous humor is going to be produced by non-pigmented epithelial cells of the ciliary body, all right? So aqueous humor is produced by the ciliary body, all right? And that's where majority or pretty much all of the aqueous humor is going to be produced. And it's going to be produced in the posterior chamber of the anterior segment, right? I want you guys to follow me, all right? I don't want to confuse anybody. So follow me here. All of the aqueous humor is produced at the ciliary body, okay? And what happens is that it flows from the posterior chamber into the anterior chamber. And then it gets drained via two networks, the trabecular network, trabecular outflow network, and the uveoscleral network, all right? And those are the two areas in which aqueous humor flows out of. The trabecular mesh is going to be like 90% of the outflow of aqueous humor. The uveoscleral outflow makes up about 10%, okay? But you have to know all of those, all right? So this is very, very key in understanding what's going on, okay? So we have medications that will help patients that have an increased amount of aqueous fluid in their eye, which is known as glaucoma, okay? And we're going to talk about those medications in a second, but I want to talk about glaucoma first. Before we get to glaucoma first, I want you guys to, once again, I'm going to walk you through the whole entire process. Honestly, forget all the anatomy I just discussed. It's not too important. What you need to know is this. The ciliary body produces aqueous fluid or aqueous humor, same thing. Then 90% of it gets drained into the trabecular meshwork, and the other 10% of it gets drained into the uveoscleral outflow tract. Okay? That's all you need to know as of right now about the aqueous humor pathway. So let's talk about glaucoma. Glaucoma is essentially an increase in intraocular pressure. Okay? They say not always is it associated with it, but in my mind, think of it as an increase in intraocular pressure. Okay? In reality, it's just optic neuropathy that causes progressive visual loss. Okay? But once again, it's going to be accompanied majority of the time with increased intraocular pressure, and that's how I think about it. Now, what are you going to see on fundoscopy? You're going to see optic disc cupping. All right, so take a look at what disc cupping looks like, because they could show you a photo of it or they could just say it in words, and that's a trigger for increase in intraocular pressure. Now, kind of just a stark difference, what will tell you that there's an increase in intracranial pressure if looking in the eye? Exactly, papilledema. So I want you to take a difference, look at what cupping looks like and look at what papilledema looks like. Cupping is going to be completely different. It's just going to be a larger optic disc, whereas papilledema shows kind of blurred lines of the optic disc. All right, and so those are the two separations you have to make in your head. Disc cupping is for increased intraocular pressure, and then when you have papilledema, that's increase in intracranial pressure. All right, now, once again, it's going to be separated into two things. You have open angle glaucoma and angle closure glaucoma, all right? Open angle glaucoma isn't too bad, okay? Essentially, it's just that you have an increase in resistance to aqueous humor drainage through the trabecular meshwork, right? So remember, we said 90% of that aqueous humor is drained through the trabecular meshwork. So when we have increased resistance against it, it's gonna lead to open angle glaucoma, all right? And the reason they call it open angle glaucoma, and I want you to take a look at it, is because there's no actual obstruction at the angle where the iris meets the actual portion of the trabecular meshwork. Okay, so there's easy flow coming in. There's no obstruction that's occurring from the iris, right? It's just the fact that there's increased resistance to drainage. Now, angle closure glaucoma is a little bit opposite. It's where if a patient has like dilated eyes, the iris, when pulled back, blocks the trabecular meshwork, and it leads to an obstruction of the drainage pathways, okay? So you have to keep that in mind. That's why they call it angle closure glaucoma, because that angle now is closed off because the iris is blocking it. Now, this is much worse, okay? It's much scarier. There's going to be huge pressure buildup, all right? And what you need to know is because of the complete pupillary block causing abrupt angle closure, you're going to have a rapid increase in intraocular pressure, and the patient's going to present with severe eye pain, conjunctival erythema, sudden vision loss, and they'll get halos around lights, okay? So it hurts very quickly. Like right when it occurs, it's going to have severe eye pain, okay? And they're going to have halos around lights. And the patient's pupil is going to be half dilated, mid-dilated pupil, because once again, that iris can't fully close. It's getting blocked off by that angle, okay? Or it can't fully open, I should say. Now, in angle closure glaucoma, there's a huge contraindication. You cannot give mydriatic agents to patients with angle closure glaucoma. All right, makes sense, because if you give an agent that dilates the pupil even further, that will shift the iris even further out and cause a further obstruction at that angle. You don't want that. It would lead to even a larger increase in intraocular pressure. All right, very scary. So you cannot give them mydriatic agents. So can we remember some drugs that are mydriatic agents or drugs that help dilate the pupil that should be completely contraindicated in patients that have angle closure glaucoma? Exactly. Alpha-1 agonists are the number one thing that can precipitate angle closure glaucoma. Okay, very, very important. There also are anticholinergics that can also lead to a mydriatic effect, which are contraindicated in angle closure glaucoma. All right, so keep that in your back of your mind. Now, the question is, how can we treat glaucoma? So there's going to be 3 different subgroups, all right, and they're all going to be aimed at each of the individual locations in which the aqueous humor is produced or is kind of absorbed. All right, so let's start with the aqueous humor being produced at the ciliary bodies. So since glaucoma is essentially just an increased amount of intraocular pressure because of the aqueous humor, we're going to want to decrease the amount of aqueous humor that's in the eye. So let's first target the ciliary body, which produces the aqueous humor. We want to decrease production of aqueous humor from the ciliary body. And the way that we do that is by giving the patient beta blockers, which is timolol, and alpha-2 agonists, which is like brimonidine. And then lastly, carbonic anhydrase inhibitors, acetazolamide. Okay, I pause there because you should know those already. Those are in your sketchy videos. They talk about it, all right? They all decrease the aqueous humor production, okay, at the ciliary body epithelium. Very, very important, okay? So the way that I remembered this one is that at the ciliary body, you have your ABCs, okay? So alpha-2 agonists, beta blockers, so that's your A, that's your B, and then your C's are carbonic anhydrase inhibitors at the ciliary body. So 2 A's, 2 B's, and 2 C's. So alpha-2 agonists, beta blockers, and carbonic anhydrase inhibitors at the ciliary body. Okay, so your A's, your B's, and your C's help decrease the aqueous production at the ciliary body. Okay, so first off, easy. Now, what's another way that we can help decrease aqueous humor in the eye? Well, we can help increase outflow. All right, so we said outflow occurs at the trabecular meshwork, majority, like 90% of it, right? So at the trabecular meshwork, we have an increase in outflow when we give patients M3 agonists. Okay, M3 agonists. All right, very important. Muscarinic 3 agonists help increase the outflow, which helps overall decrease the intraocular pressure. All right, but once again, if you give them muscarinic antagonists, that's going to lead to decrease in drainage, and that can lead to glaucoma. All right, you have to remember these. These are very, very straightforward. You know these drugs, okay? It's just a matter of memorization. And the last one is going to increase outflow at the uvea sclera, and that's going to be prostaglandin agonists. And the way that I remember this is UPS. U is for uvea, P is for prostaglandin agonist, and S is sclera, okay? And it helps ship things out like the UPS does, okay? So overall, let me just run through this really, really quickly. You have 3 pathways in which the aqueous humor is produced and drained. The first one is that at the ciliary body, it's going to be produced. The other 2 help drain it at the trabecular meshwork and at the uvea scleral outflow tract. You have different medications which affect different ones, okay? Alpha-2 agonists and beta blockers, as well as carbonic anhydrase inhibitors, all help decrease the production from the ciliary body. Then you have, at the trabecular meshwork, M3 agonists, okay, muscarinic 3 agonists, that help increase outflow of aqueous humor. Lastly, you have, at the uveoscleral outflow tract, prostaglandin agonists, which also help increase outflow. Whenever you have angle closure glaucoma, there's a huge contraindication to any drugs that dilate the pupil, specifically alpha-1 agonists and anticholinergics, okay? Because if you cause the pupil to dilate, it leads to a severe acute angle closure glaucoma, which causes severe eye pain, conjunctival erythema, sudden vision loss, halos around the eyes or around lights, as well as mid-dilated pupils. Okay, so keep that all in the back of your mind. Although it's not too high yield, I think that all the drugs that I got tested on were very, very high yield for glaucoma.